Okay, so hi everyone. I'm Ariela Frieder. I'm a perinatal psychiatrist and the medical director of PRISM for Moms. I think all of you know me by now, so that's great. So today we are going to be talking about screening for substance abuse. So let me share my screen. And let's see. Good. Let me make you smaller so I can see the slideshow. So I think this is such an important topic to discuss, and I want it to be very interactive. I want to hear your ideas and thoughts on how you do things, because we need to reach more people and we need to treat more women with substance abuse and find them and have them be in treatment, because it's so important. One thing I want to say is that pregnancy is really a window of opportunity during which many women stop. If they don't stop using during pregnancy, it's because the severity of their substance abuse is really higher, and they really need our help. So it's great to find them, to make sure they stop during pregnancy, but then to help them continue with that abstinence later on in life. So that's why, for me, it's so important to screen for substance abuse in pregnancy, in postpartum, and also we'll talk more, but about the negative effects on the mother and the baby and the family and the community. So let's start by definition of addiction. I put this here because I feel sometimes people don't take it seriously in terms of like thinking it's just like, if you have a family member that is using substances, some people think, okay, they can just stop it. They can just get over it. I hear that word all the time, get over it, And the reality is that it's an illness, and I like this definition because it shows us how broad the problem is. So addiction is a primary chronic disease of brain, of particularly reward, motivation, memory, and related circuitry. And dysfunction in these circuits leads to characteristic biological, psychological, social, and spiritual manifestations. So it really encompasses all the person, all the being, And this is reflected in an individual pathologically pursuing reward and or relief by substance use and other behaviors. So this is very important to give it the seriousness it deserves. So what are the characteristics of addiction? One is the inability to consistently abstain from using, impairment in behavioral control, cravings or increased hunger for drugs or rewarding experiences, diminished recognition of significant problems with one's behavior and interpersonal relationship, and a dysfunctional emotional response. I think this is a really good summary of what it looks like, addiction, because we will hear it when women come to us and they can't stop. So I'm going to give you some statistics that I think it's important to have in mind to see what the severity of the problem is. So SAMHSA, the Substance Abuse and Mental Health Service Administration, estimates that around 22% of women use alcohol, tobacco products, or illicit drugs during pregnancy. This was in the years 2013 to 2014. And women that use drugs in pregnancy are likely to have a delayed prenatal and substance abuse disorder curve, which, as you can imagine, will result in poorer maternal and infant health outcomes. And what are the substances that people use the most? Is usually alcohol and tobacco are the most prevalent during pregnancy. And so here you see estimates in 2013 and 2014 that 9.3% of pregnant women use alcohol, 13.4% use tobacco products, and 5.3% used any illicit drug. And at that time, marijuana was in that 5.3%. And what is very important, and this has something to do with what I said before, is that fewer women use in the third trimester compared to first and second trimester. And this has to do first when they found out they are pregnant. And really, women pregnancy is a moment that women really try hard to stop using. So there is less women that get to the third trimester using compared to the first and second one. So I wanted to talk about with drug abuse. And as you know, drug use in pregnancy is a serious public health problem in Montana. There is a shortage of treatment for pregnant women with substance use disorder. And there are the numbers of children in foster care more than doubled since 2011. And here you can see out of more than 3,200 children in foster care in 2016, 64% were removed from the homes for reasons related to substance abuse. And among Medicaid patients, the percentage of infants with perinatal drug exposure increased from 3.7 in 2010 to 12.3%. And despite the growth of this problem, as this was data from 2016, only 6% of Montana state-approved substance abuse disorder facilities reported programs for pregnant and postpartum women. So this is really a problem that we need to help solve. And here I just wanted to mention, states have different policies, and some states talk about substance abuse in pregnancy as child abuse. Some of them consider it grounds for civil commitment. Some of them make that the healthcare professional has to report the suspected prenatal drug use. Some mandate to test women, require them to test the prenatal drug exposure if they suspect drug use. And some states have programs that are funded for pregnant women with substance abuse. And there are some states that prohibit to discriminate against pregnant women that are using. In Montana, one of the things that is important to know is that when drug use is diagnosed or suspected, the state requires reporting. So there are differences between men and women in terms of substance abuse. And one important difference is that how women start using, it's in different contexts compared to men. Men might start doing it by themselves more. Women, it's usually in the context of a relationship, a romantic relationship, or family members or peers using. And women sometimes hide to use. So it's a different pattern. So in women, who are the women that are at risk for substance use disorders in pregnancy? So as we said, women that use substances before pregnancy, when there is a history of substance abuse in the family, when the partner is using, and when their peers are using. All those put women at risk for substance use disorder in pregnancy. And remember, women that don't stop, the severity of their substance use is higher because it's very hard for them to stop. So here you see what are the risks of substance use disorders in pregnancy. So in terms of pregnancy risk, there are birth defect, poor nutrition, poor prenatal care, delayed prenatal care, unexpected pregnancies, many times a placental insufficiency, which can lead to preterm delivery and intrauterine growth retardation. There is and we'll talk more about this, but there is a very tight relation between substance use disorders and trauma and violence. And that's very, very important to keep in mind because it's not just identifying the substance abuse. You also want to identify the situation at home, if this woman is safe, if there are any risks going on at home or in their environment that can make her unsafe, you know, so that's very important. The other thing that is important, and we will have a lecture that is just about trauma, but it's very important how you relate to these patients, to every patient. You know, you need to be very careful because they have a history of trauma, and the way they perceive you and the way they relate to you, that interaction might lead them to open up and talk, or close in and not tell you anything. So you have to be very much aware that this woman might most likely went through trauma and violence. The other risk of substance use disorders in pregnancy is difficulties with labor management. You will see that there are problems with pain medications for some of these women. Sometimes it's them don't wanting them, sometimes they need higher doses, and sometimes it's that the health providers don't want to give them medications for pain because of their concern with substance abuse. There is risk of overdose, there is risk of withdrawal and intoxication for mother and the baby, and risk of HIV, hepatitis C, and hepatitis B. So in terms of screening, it's very, very, very important to screen for substance use disorders in pregnancy and postpartum. So you should screen always at the first appointment and once per trimester for sure. But if you have any concern, you know, and some guidance say you should screen every visit, you know. So this is a short screen that is used by some states, like let's say Massachusetts uses this screen. It has 4 items, and it talks about alcohol, tobacco, prescription drugs for non-medical reasons, and illegal drugs. If any of these questions becomes positive, you should follow up with a more in-depth screening. But this is one of the screening that some states are using and seems to be very straightforward. The other screening that we use a lot is the audit C. This is for alcohol. In some places they use it combined with a short questionnaire for marijuana, for cannabis, and for a one question for illegal substance use, and we'll talk more about that. But the way it looks, it starts with these 3 questions, you know, and how often did you have a drink of alcohol? Within the past year, how many standard drinks containing alcohol did you have on a typical day? And within the past year, how often did you have 6 or more drinks on one occasion? If a woman screens more than 3, it means she's at risk of alcohol abuse, and we need to do the complete audit C that I'll show you in a minute what it looks like. So this is the audit. And as you see, it's a 10-item questionnaire, and it's a little bit more in depth. And with this one, you will assess for severity of using alcohol. And here you see the scores, you know, and where do they are depending on the scores. So 0 to 3 is low risk, 4 to 9 is risky, 10 to 13 is harmful, and more than 14 is severe. And it, depending on the result, you will decide what kind of intervention you will have. So if somebody scores 3, or between, I would say between 3 and 9, you can have a brief intervention that will be motivational interviewing. You will try to educate the patient, make her gain insight into her behavior, and trying to elicit change, you know, work with them in terms of like, what do they see that is the problem, how they can change what's going on, and start the conversation. Some women might not be ready to stop at the moment, but they might be ready to start a conversation. If they score 10 to 13 that is harmful, you will be more targeted towards abstaining and reducing the substances when you discuss with them, and you will have a follow-up in place for them. And if it's severe, you will really try to refer them for treatment for a full assessment. So for other drugs, you can use just this single item drug screen, and it says how many times in the past year have you used an illegal drug or used a prescription medication for non-medical reason. And if asked what non-medical reason means, you can say because of the experience or feeling the drug caused, you know. And in this, you can add cannabis, you know, and it's important to know if they are using any drugs or if they are using cannabis, even that some women don't perceive it as a problem for the child, you know, but it's important to know because you need to educate them and explain them the negative consequences of using these drugs. So if they score positive for this, you will follow up with a more in-depth screening tool. And the one that I like and that people use is the DAST-10. It's the drug abuse screening test. And here you see, you will ask them about if they use drugs other than those required for medical reasons. Do you use more than one drug at a time? Are you able to stop using drugs when you want to? Have you had blackouts or flashbacks as a result of a drug use? Do you feel bad or guilty about your drug use? Does your spouse or parents ever complain about your involvement with drugs? Have you neglected your family because of drugs? Have you engaged in illegal activities in order to obtain drugs? And have you experienced withdrawal symptoms when you stop taking drugs? Have you had medical problems as a result of your drug use? So it's pretty comprehensive in terms of like trying to figure out the situation. And here you have the scores of this test, and you see that more than 3 requires further investigation, you know, and more than 6 requires intensive assessment. So the other thing is that when a woman comes to you, you know, and you are seeing her, you need to know what to look for, and based on that, what are you going to do about it, you know? So what are behaviors that require to gather more history? One is like if you give, so I always tell women that, because I prescribe some substances that can be abused, you know, and I tell them, you know, if you usually, if the patient takes it as prescribed, that's one thing. But if you see that you give them one day and they call you very few days later saying I'm running out, or they by themselves are escalating the dose, or if they are very focused on controlled substances on getting them, if they spend a lot of time or resources on obtaining controlled substances, if they, what I said, if they request early refills, you know, if there is any evidence of tolerance or history of withdrawal, that will make you look more into it to make sure there is not substance use disorder here. What are the behaviors that require close monitoring? Women that lose prescriptions for controlled substances, requesting specific agent, route and frequency, purchasing illicit drugs, taking diverted opioids, multiple providers prescribing controlled substances. We have systems that we can go and look who gave the prescriptions and when the prescriptions were given, and we are actually, we need to do it. It's not something that I can go and look. Every time I prescribe a controlled substance, I have to go and look and make sure that nobody else gave the medication to the patient, nobody else, when was given, to make sure that I'm giving it at a good lapse of time, you know? So all those things are important. any mood or personality changes, and emotional lability. All that will make you think you need to close monitor this patient. And what are behaviors that require immediate intervention? Clinical signs of intoxication, signs of withdrawal, evidence of tampering with IV or hoarding pills while in an inpatient setting, crashing, injecting, snorting pills, seeing drug use paraphernalia, physical signs of injections, stigmata of chronic alcohol use, intranasal irritation. So all these signs will make you think the woman is using and I need to do something about it. I need to get her into treatment now. So as I said before, very, very important, is trauma. So 1 in 3 women in the US have a history of sexual and or physical abuse. And violence goes hand in hand with substance use disorder. So this is very, very important because more women, and I feel like I don't need to tell you, you know that already, like will have a history of trauma. So social determinants of health can exacerbate the effect of substance use disorder in women. And what are the social determinants of health? Are the conditions within a home, family, school, and community that can impact a person's ability to be healthy. And it includes the physical characteristics of the neighborhood a person lives in, access to healthy food, safe housing, quality education, and economic well-being. And this is so, so important because it doesn't start, it's not just the person. You have to look at the bigger picture, If the woman lives in an area that it's like known for people using a lot of drugs and she has to go back to her environment, it's very hard, she needs help with that. Some women will need help to get off their environment, Some women will need help getting a safe housing, like it's very, very important to look at the broad picture. The other thing I wanted to mention is adverse childhood experiences. When we talk about trauma, there is a strong dose-dependent relationship between one's exposure to abuse and dysfunction in childhood and risk factors for the leading cause of death in adults. And this is very interesting. Only 10% of all health outcomes may be attributed to actual medical care. In contrast, 40 to 60% are attributed to social and behavioral factors. So this is so, so important because you need to know this woman was subjected to abuse as a child, neglect, and household dysfunction, and how that is affecting them today and make them more prone to use drugs. So here you have this pyramid that shows you how starting with historical trauma and going up to early death, all the things that are in place and make things worse and worse. And as you see, at some point, women are more, or people in general, when they have all the adverse situations in their life, they are more at risk of having risky behaviors, including substance abuse. So the American College of Obstetricians and Gynecologists recommends screening for trauma, PTSD, and intimate partner violence. There are different questionnaires, and we will talk more next time when we talk about trauma. But I just wanted to mention them. I wanted to mention that it's so important when you are screening for substance abuse to also screen for trauma. And one thing it's important to know, what are the challenges that women with substance abuse have during pregnancy? So the stigma, the shame, that some have more severe illness and they can't stop using, any legal issues. Some of them don't recognize they're pregnant until longer into pregnancy, and the access to care. That's very important. And I wanted to mention SBIRT. SBIRT has been found to decrease the frequency and severity of drug and alcohol use, decrease hospital stays and emergency department visits, and demonstrate net cost savings. So the screening to identify unhealthy use, 75 to 85% of patients will screen negative. And for those who screen positive further assessment is needed to determine level of risk. Then that will follow with a brief intervention. And the brief intervention will provide feedback about that unhealthy substance use, will focus on education, increasing what we spoke before, patient insight and awareness about the risk related to the unhealthy substance use, and will work with the motivation, will really help them make changes in the way they think, they feel, and motivate them to stop using. And then for some women, you will need to refer them to treatment. But this has been demonstrated that it's very helpful in many health places to work with substance abuse women. So I wanted to stop now, and I wanted to discuss with you what are your what do you do? How is in your place? You know, one thing I wanted to mention also is that a lot of women will be concerned about CPS, you know, about involvement of child protective services. And I've had patients in the past that they might go to different hospitals to give birth, not the place where they were following up, you know, because they are concerned of child protective services being called, you know. And I think it's very important first to build trust with the patient when you meet them, and over time to discuss all those possibilities and to discuss what it means to call child protective services, you know, if you have to call them, and what it entails, and so they are not surprised, you know. So and their fears can be minimized with that. It's a very difficult situation for any woman, but they need to know about it, you know, and they need to hear from you about it. So I have questions for you now. One thing I was thinking, because when I started working in this area, I was thinking, I want to do a urine screen to each woman that walks through the door that is pregnant to see if she's using any drugs. And I didn't have much quorum from the obstetricians to do that. At that time, there wasn't even screening, like this kind of screenings, the questionnaires, like weren't using them. But I think there are some women that needs the urine screen, you know, when you are seriously suspecting somebody's using and they are not telling you, you know, it will be good to do a urine screen. But I wanted to know, how do you do in your places? How do you approach women with substance abuse? If you do urine screens, if you do questionnaires, what do you use?
So I can go first. This is Callie from Logan Health in Kalispell. Yeah. So as part of the Metal Arc, we have to screen all new patients, all patients at regular intervals. So we use the audit C+2. We don't have currently any drug screening protocols in place for actually urine drug screens. If a patient has a history or discloses use, then we will ask if they want to do a UDS just for information for us. If they've already disclosed, then we say, okay, we already know you're using, but let's get a baseline. And then we talk about that ongoing testing for them. But in our hospital, we have to get parent permission or patient permission to do urine drug screens. When the baby is born, if the baby goes to the NICU, we automatically drug screen all babies that go to the NICU. Whereas if a mom presents to deliver, baby doesn't go to the NICU, we don't necessarily screen those babies. So that's where it gets a little bit tricky. But yeah, that's kind of what our policy is for self-reporting screening as well as UDSs across the board.
And do you do the UDS, you do it observed, or you just give them the cup and tell them to do it?
We just give them the cup and they go to a room. All the rooms are really small. So the likelihood that someone can go in with them is pretty limited, but yeah, we don't observe them. We kind of do it on an honor system to make sure they're, we've only had one that came back that was really goofy. She reported she was on MAT and that didn't come back in her urine, and there was all these other things that came back. So we're like, wait, what is happening here? And I don't know if we ever got resolution with that, because then she delivered out of the area. But yeah, we've only had one that was not what was reported to be happening.
I see. How other people are doing? Are you guys screening for substance abuse?
I'll echo what Callie said, because I'm also under the Metal Art program. So we're using similar tools or the same tools. I'm kind of exploring, what it means to screen and kind of ethical screening. And when you have screening in place, is it ethical to screen if we are not following through? So are we just taking, what are we doing with this? What are we having in place after the screening? Are we actually doing and following through with ESPERT? Do policies in place that are, trauma informed and culturally appropriate and things like that. So taking that into consideration, when people are doing PHQ-9s or GADs and the screening for substance use, that we just aren't screening people and just walking away from those screenings, that we're discussing those and using good engagement skills, and then also doing that brief intervention. And that might be difficult when we have low resources in some places, where there isn't maybe some integrated care set up, where that brief maybe intervention with maybe a healthcare provider that can sit down and discuss things and not, help, give them the help and resources that they need. And so I think some of that can be an issue or worth thinking or talking about. I did have, some issue taking down data from my report where we haven't had to do a lot of urine screens. I'm similar to Callie. It's kind of been patients who have asked for urine screens mostly, or, I would like to do a urine screen because I don't want Child and Family Services, and I want to prove that I'm not. Or we've asked for consent. I'm in that case. But interestingly enough, going back through the data, the only person that I noticed got a urine screen was a person of color. And that really kind of bothered me in a lot of ways, about our data. And so to bring that up with the provider, you didn't screen anybody. You do a urine screen on anybody but a person of color. And what does that mean for you? And I couldn't find anything that she didn't score on any of the screenings, and there was nothing there to back up why the decision was made to do a urine screen. So anyway, interesting uses of data.
Yeah, that's interesting. It's a very delicate subject, and as you said, doing it in a trauma-informed way is so important, like keeping the dignity of the woman and not making her feel less or that you are judging her in any way, and that you are here to help her. So I think it's a lot of establishing also a relationship you know, and invest so they can trust you, you know, and let them help them, because really pregnancy is a time that you can, they are more motivated to stop, you know, they are really more motivated to stop. So if you in a situation that you can help them, you can have good success. I see, so in my practice, I see a lot of women that stop using in pregnancy and then resume after the baby is born. And that's really sad, you know, and so it's very important not to lose them in the follow-up after. I don't know if you see that too.
Something that we're working on here in Kalispell is using the screeners that we use with Meadowlark and presenting those to the pediatric clinics for use in those clinics as well, to continue to reassess for both mental health and substance use after the baby is born, and providing those follow-ups, like when a patient screens positive, here's what you do, since that's a big deterrent for clinics even screening, is not having a plan afterwards.
Yeah.
So that's something that our we just changed the name, Perinatal Mental Health Coalition is going to be addressing over the next year, is at least doing the screens in those clinics, and then having a toolkit of when you screen positive, here's the information you can give the families to reach out for additional support. For that. So hopefully that will help with that follow-up, because sometimes people do fall off the radar after delivery, and there's only so much that I can personally do in a hospital system. I can't go to their home and find them. I can't just call law enforcement and say, hey, I need a welfare check. Like, there's only so many things I can do to connect with that patient after delivery if they refuse to answer their phone.
Yeah.
So.
That's right. That's right. Yeah. It's really hard. So I was wondering if you have any questions or any comments. I have a case that I would like to discuss. So
I guess I just have one more comment, that between last session and this one, I love that you provide those extra tools for further screening, because I feel like it helps give us the tools to guide conversation a little bit better. So for using the DAS-10 after they screen positive for substance use, and using the additional mood screening, I can't remember what that's called, but using that after they test positive for depression before starting medication. So I like that you're providing those extra tools that we can use to get further information before we take extra steps. So thank you for that.
Any questions?
I have a question, Dr. Frieder. If you find that one of the biggest reasons that women don't disclose that they're struggling with substance use is that they're afraid of CPS getting involved, at what point, like in what order, do you think that it's best to explain kind of like how that will go and what you know about the system and how that all works? Because I feel like it's a tough balance between sharing too much information, which would like make an assumption about them, right? But then also, if you know that that's a fear, do you have how do you do that?
So that's why one of the things that for me is very important is to establish a relationship. The ideal situation will be that every time that a woman comes to the clinic, the same person will be doing the screening, you know, so the woman knows you and trusts you and understands that you are there for her best, you know, you're trying to help her. So I think that's one of the first things, you know. And then at some point, I will have a frank conversation, you know, like depending on the situation of like telling them, like I had really bad situations when people didn't know I was a mandated reporter, you know, and then having to report them. And women get very upset, and they are right, you know, to get upset if they don't know that they are sharing with you things, they are trusting on you, and then you are going to go and report them, you know. So I have I have colleagues that they tell them it the first time they meet, I'm a mandated reporter. If you tell me something that is unsafe for you or for your child, I need to report it, I think that's a little bit too much, like to just start the conversation with that, they might not see you never again. But if you can establish first a relationship with them, then you can bring it up and tell them the truth, like I'm here to help you, and I don't know, I'm an advocate for my patients. So even with CPS, I always advocate for them, and we have good results many times, because the patient is working hard, I'm supporting them, and CPS sees. That's what I explain to patients, that being in treatment, it's a plus, for CPS, like being in treatment, taking your medications, going to therapy, going to groups, doing what you are supposed to do, to parenting classes, all that is a plus for you. So I think once they realize that I advocate for them, that's very, very helpful. But it's not an easy conversation to have. Yeah. Any other questions? I have a patient now who I would say it's a complex case, She has a history of abusing Xanax, and really bad, like in the past. And then she got married and she went to her honeymoon and she forgot to take the Xanax. So she kind of withdrew from the Xanax, without wanting, But now she's in clonazepam, somebody after that started her on clonazepam to keep her stable from her anxiety. She has anxiety. She says she has ADHD and she clearly has bipolar disorder. And she is on a mood stabilizer, Seroquel, and she is on Vyvanse for ADHD and including. And she wants to get pregnant. So she came to me for me to help her to get pregnant on these medications. And she also takes Prozac for OCD. So I started meeting her, I started knowing her more. And she really minimizes the bipolar disorder. No, I don't think I have bipolar disorder, And I'm very proud. I stopped Xanax, which I'm very proud of her. And I always tell her how proud I am of her for not using Xanax anymore, And now she's supposed to take the Klonopin in a way that I prescribe, But there is always a problem, She always runs out before time, or she calls me before because she feels she needs a higher dose. So I had a meeting with her and the husband last week to see what to do, like how to help her. And I'm starting to feel, like the substance abuse is not over, like it's still there, And so I try to point out to her, like even if we are going to use the clonazepam in pregnancy, we need to start going down, we need to start having a plan of how you are going to stick to what we say. And it's really hard because she doesn't want to accept that this is a problem. So I was wondering if you have any ideas or any suggestions on that.
I'm just curious, does she have a therapist that she can also work through some of her, obviously, some of this, but also even ADHD management and things to maybe help her be able to stick to a plan better?
Great question. because we have been, since I met her, I think 3 months ago I met her, I have been telling her that she needs a therapist because there is so much I can do, you know, she needs somebody to meet every week and to help her, yes, with the ADHD, with her insight, you know, with her understanding of what's happening to her and her substance abuse. So we are working on that, on getting her a therapist.
And do you think the bipolar diagnosis is accurate for her?
Yes, I think so. I really think she has bipolar disorder. She has periods of not sleeping with increased energy, very impulsive at that time, you know, very like gets angry, aggressive, you know, during those episodes. It seems to me that, yes, she has a diagnosis of bipolar. I'm not sure, you know, it's very hard with ADHD, you know, like is it real ADHD or is more like the inattention associated with when she has episodes of mood, you know, but that's another thing, you know, when you start seeing somebody new, it's hard to tell them you don't have this, I'm going to take you off this medication because they will not come back to you. So if you want to help them, it's kind of, you have to compromise. So I changed her from Vyvanse to Adderall because there is more information about Adderall in pregnancy. But yes, I'm still evaluating her in terms of the ADHD.
I think these cases are always hard, and you're doing a really good job in trying to be proactive because right now time is to your advantage and that she's not pregnant. But once she becomes pregnant, this of course will escalate very quickly. So I think doing what you're doing and sort of thinking about, okay, if I removed the emotion from the situation, what ideally do I think she needs to be on to get her pregnant and to be able to handle the medications and of course keep her mood stable during pregnancy, and then maybe even present that to her, but then figure out, okay, how can we be proactive and have this plan in place of getting you a therapist that you can meet with weekly to create even sort of a safety plan and have a safety net, even if she were to get pregnant, like to utilize the Postpartum Support International Bipolar Disorder Support Group that they have now might be really helpful for her, as well as any sort of, you know, substance misuse support groups if needed as well.
Yeah, I agree. Yeah. One thing we are working on is also how to decrease her stressors during pregnancy because she works, she has her business. So, but she has a partner at work, you know, so we are talking how she will manage to have less stressors during pregnancy so she doesn't feel she needs so much the clonazepam, you know, so I think it's, and also involving the husband was very important. So he is on board. He knows what are the red flags, what to let me know, you know. So she's lucky she has. So.
Would you recommend keeping her on the Prozac given her bipolar and if she gets pregnant?
Yes, because she has really bad OCD, and it seems that the Prozac really help with the obsessions and the compulsions. So I don't want to touch it. You know, it's a really difficult case because she's already on 4 medications, and I feel uncomfortable having her on 4 medications in pregnancy. But some people need it. You know what? You try to go down as much as possible and have a therapist, decrease stressors, you know, have support, but sometimes the reality is different.
Yeah, I was just curious about postpartum psychosis, like if you would be worried about that with that medication.
Sure. No, not just because of the medication, I will be worried with her history, you know,
of course.
Bipolar. Yeah, that will make me. So that's I'm not even thinking about the postpartum, you know, now like I'm.
Oh yeah.
But that will be a conversation to have and to prepare for that. I usually do that. I have one meeting with them and husband or the partner or whoever is in the family that is involved. And I discuss the red flags of postpartum psychosis and how to contact me and who will contact me and what we will do if something like that happens, you know.
Yeah, and then if she were to get pregnant, you know, just tapping into all the resources that are available to her, depending on which community she lives in. You know, if there's a visiting nurse program or any sort of community organization that she could get established with during pregnancy instead of waiting to the postpartum period would also be helpful, I think, too.
Yeah, I agree, totally. Yeah, thank you.
I'm kind of curious as to why she feels like she needs to minimize the bipolar symptoms and why she needs to minimize that diagnosis itself. Is it, you know, was there a previous situation that made her uncomfortable for having that diagnosis? And I'm also wondering if the medication increases that she's requesting are because she's recognizing symptoms and doesn't know how to deal with them. So she's like, no, I need to up my meds so that I don't have to acknowledge that this is something I'm dealing with.
That's a great point, actually. So she used to be on lithium and she didn't like it at all. She felt too many side effects. She gained weight. She was sedated, you know, so she doesn't want me to even think about the lithium, you know, like, so I think that's where it comes from, is that she was overly medicated in the past and felt really not well. And now she's in a good place, more or less, how she feels. But it's true what you say, that her asking medications, you know, I think part of it is that the fact that it's hard to deal with frustration, with negative emotions. And when you have a history of dealing with that with medications, you know, it's hard to tolerate negative emotions. So I think it comes more from there, that she wants me to give her something, so like a Band-Aid, you know, for her negative emotions, because she seems stable in terms of the bipolar, but it's like a lot of anxiety and yeah, getting upset when there are situations, you know, that make her upset.
Yeah. And hopefully a counselor is able to kind of address some of those underlying
Yeah,
issues and how to cope with those difficult emotions that she may have not ever had to deal with before. And that's,
yeah,
that social emotional learning is really important, but really hard, especially as an adult.
I agree. Yeah. Thank you. This is helpful to discuss. And I think, you know, if you want to bring cases, you know, that will be great, you know, like we can talk about one case every time we meet. So I think it's very enriching to discuss and get the idea of everyone else in the group. Any questions? Any thoughts?
Speaker. Hey, this is Jana.
Hi.
I went to a conference last week in San Antonio, and the talk on perinatal moods and breastfeeding, she said that Wellbutrin was not indicated for breastfeeding, so we had to wean him off of that. And I've used it for years. And yeah. I was like, oh, and she was also really not happy about like people being on Adderall or stimulants. And I'm like, oh man.
Listen, so you really have to read the literature and understand the literature. The ideas that Wellbutrin are not helpful, are not good during breastfeeding, and are based in 2 case reports where babies had a seizure. But it's very hard to say that because of 1 case report of 1 baby, you know, that makes the assumption that every baby that will take Wellbutrin will have a seizure, you know?
Mm-hmm.
So you have to look at the literature in general. You can't just decide based on 1 case report. that's
Yeah.
in terms of that. And the other, I think we spoke about that, and we'll speak more when we talk about ADHD, but there is enough information to suggest now that if a woman really needs it, yeah, there are risks. But if she really needs it, she needs it. That's more important than the risks. The benefits outweigh the risks. So
Yeah.
it's always, you have to put it in a balance and see what more risky.
Yeah. Okay. Yeah. I mean, I wasn't changing my practice based on it, but I was like, interesting. I'm going to ask Dr. Frida what she thinks about that comment.
Yeah. I'll send you information if you want.
Okay. Thank you.
Sure. Any other questions? Good. So it was so nice to see you all. We have in a month, we'll meet again and we'll discuss trauma, PTSD, very important and very related to what we spoke today. So I'm looking forward to seeing you all in a month.
Thank you.
Thank
Bye.
you.
Thank you.